Hello everyone, and welcome to week 5 of Bio 6601, Environmental and Biological Ethics. I'm Dr. Kaylin Fogelman, and today we're going to explore a sensitive but crucial topic, death, dying, and end-of-life ethics. While the formal lecture is a bit shorter this week, the bulk of your learning is going to come through case-based analysis. We're going to work through some real-world scenarios that will help you apply ethical frameworks to complex end-of-life decisions. So today, let's lay the groundwork so that you'll be able to engage with those cases thoughtfully and critically. Death is something that every human shares, yet it remains one of the most avoided conversations, particularly in Western cultures. But in the world of medicine, avoiding the topic is not an option. Those that are involved in medical fields will face death frequently, and they must make hard decisions when patients can no longer speak for themselves. Medical advances have blurred traditional definitions of death and dying. Technologies that sustain biological function can prolong life, or in some views, prolong death. End-of-life decisions impact more than just patients. They touch families, physicians, institutions, and entire healthcare systems. That is why ethical frameworks matter. They help us to navigate these moments with integrity, compassion, and structure, even when personal beliefs, legal standards, and cultural norms conflict. We're going to lean in on 4 key principles in biomedical ethics when making our end-of-life decisions. These are principles that we've seen before, with the first being autonomy. Patients have the right to make decisions about their own care. That includes refusing treatment or requesting comfort-focused care. Healthcare providers must honor those decisions even when it's difficult. Providers also need to be open and truthful about diagnoses and prognoses, because informed patients can make autonomous choices. Our second principle is beneficence. Providers should act in the best interest of the patient, but this must not override the patient's values or their preference. Then we have nonmaleficence, do no harm. But what constitutes harm? This gets complicated in cases like physician-assisted suicide. Some providers view participation as a violation of non-maleficence, even if it is what the patient desires. And finally, we have the principle of justice. So this principle reminds us that all patients should receive fair and unbiased care. Discrimination, whether that is conscious or unconscious, has no place in end-of-life treatment. So to empower patients in these decisions, Congress passed the Patient Self-Determination Act in 1990. This law requires healthcare institutions receiving Medicare or Medicaid to ask patients if they have an advance directive. This is something you may have experienced when you were checking into an appointment at a specialist or at a hospital, visiting emergency room maybe. A lot of times when you're checking in, they'll say, do you have an advance directive on file with us? So if they're receiving an institution that's receiving Medicare or Medicaid, they are required to ask that. They're also required to provide information about legal rights to make healthcare decisions and prepare those directives. So the Patient Self-Determination Act is essentially codified patient autonomy into law, and it emphasized proactive communication about future care. So advance directives can be verbal statements by the patients of their wishes, a living will, which is a written statement of the wishes, or identification of a proxy decision maker or a proxy directive. So let's look at that a little bit more in depth. What exactly is that advance directive, or what are those legal tools to help patients with their autonomy? The advance directive is instructions that the patient makes ahead of time in anticipation for a scenario when they may not be able to communicate their wishes. So an advance directive can include living wills, which state that person's preference for pain management, resuscitation, feeding tubes, or where they would like to receive care. The verbal directives, especially if recorded or witnessed, can be included in an advance directive, or things like do not resuscitate or DNR orders. So that it could include organ donation preference and things along those lines. Another really important element in an advance directive is the appointing of a healthcare proxy. So when someone appoints a healthcare proxy, that's someone who can speak on the patient's behalf when the directive doesn't cover everything. So while a directive may cover a lot of stuff, like a desire for pain management, a desire for nutrition, where they would like end of life care to take place, whether they want life sustaining interventions, what are their wishes for organ transplant or organ donation, an advance directive may not cover every situation that may arise. But if a healthcare proxy is designated, that allows another individual to make choices on behalf of the patient should there be things that were not covered in an existing advance directive. So the person that is a healthcare proxy might be a spouse, a child, a sibling, or a trusted friend, and typically they're named in what is called a durable power of attorney for healthcare. So again, this could be a legal guardian, a spouse, domestic partner, doesn't necessarily have to be married. It could be an adult child, parent, siblings, a friend, somebody that is designated legally to make decisions on the patient's behalf. So laws that exist on advance directives can vary state by state. So we'll look at an example, Alabama Code Title 22. So under this law, any competent adult can create a living will to guide treatment decisions, including the use of things like feeding tubes or ventilators. But artificial nutrition and hydration cannot be withdrawn unless the patient specifically allows it within the document. The law also allows patients to assign a healthcare proxy who can make decisions about life-sustaining treatment. This legal backing ensures patient autonomy is respected and that surrogates have the authority to act on the patient's behalf. So let's begin a deep dive into the Georgetown University Ethics Workup. This is a 5-step model that helps clinicians, ethicists, and even families make morally sound decisions in complex healthcare situations. So this is going to be some guiding framework that we can use to help us make decisions as far as end-of-life care goes and the ethics associated with that. So step 1 is very simple, but it's essential. Gather the facts. Before we can even ask questions, we need clarity on the basic reality of the situation. So that means both medical facts and social context. So you might use the 5 W's, for example. Who, what, when, where, and why. Who is involved? The patient, family, surrogate decision makers, healthcare team. What is the diagnosis and prognosis? What are the treatment options? When did the condition progress? Are we at a crisis point? Or is there time to plan? Where is care being delivered? Hospital, hospice, ICU, the intensive care unit, at the patient's home? Why are we here now? What are the goals of care? Cure, comfort, prolongation. Social considerations might include another what. Does the patient have strong cultural or religious preferences? Are there language barriers or socioeconomic issues at play? So for example, let's say a patient is in advanced stage ALS. Medically, we know it's a progressive neurodegenerative disease. Socially, they live alone and their sister is their only support person. These facts would shape everything else. So you have to, much like some other decision-making frameworks we've had, what is the basic information going into this? So now that we've laid out the facts, then we can move on to step 2. What is the issue? This is where we figure out why a decision is ethically hard. Is there a disagreement? Is there a rights-based issue? Are there competing duties? So you want to ask things like, is this conflict personal, so within the patient? Is it interpersonal, such as family versus physician? Is it institutional, hospital policy versus best care, or even societal? That could be a legal versus a moral issue. So sometimes what seems like an ethical issue is really just a communication breakdown. For example, if a patient's family is insisting on everything possible for their care, but the patient has a do not resuscitate order. Is that an ethical tension or a misunderstanding? So we also want to ask, does the issue involve rights, obligations, or harm? These are our ethical red flags. So this step is all about clearly defining the core tension, kind of like a thesis statement of the paper. What is the issue? What is the thing that we need to address? So now that we know what the issue is, step 3 is to frame it clearly and fairly. This means organizing all the ethical elements into a coherent picture and identifying what values are in conflict. So there are 3 parts to this step. First, identify the decision maker. Is it the patient? Great, if they have capacity. If not, who is the surrogate? Were they appointed legally, like with a durable power of attorney for healthcare? Are they making decisions consistent with what the patient would have wanted? Keep in mind that not every patient designates a surrogate. Sometimes it defaults to the next of kin. We also need to apply clinical and ethical criteria. So what is it in the specific biomedical good or best interest of the patient, like preventing suffering? What is in the broader interest of the patient, like dying at home versus dying at the hospital? What is in the interest of others, like the caregivers, the family, or even society? We have to define the obligations of all parties. What duties do the healthcare providers have professionally and morally? What are the expectations for the surrogate or guardian? Is the surrogate upholding the patient's wishes, or are they imposing their own values? So for example, imagine an unconscious patient in the ICU that has no advance directive. The son of the patient insists on full code measures. He wants everything done, but nurses know that the patient has previously stated they did not want to be kept alive with intervention or on machines. So who decides? How do we balance the family's wishes with the prior statements of the patient when they did have capacity? So this brings us to step 4. This is our action step. This is where we evaluate all possible courses of action, then we make a decision. So this is where our ethical reasoning really flexes its muscles. What are our options? What are the pros and cons of each? What values are promoted or violated by each choice? Here are some key questions that could be weighed. What are the harms and benefits of each course of action? Is the patient informed or able to participate in shared decision making? How will this affect the family emotionally and practically? Are we respecting cultural and religious values? Is the decision cost effective or using resources wisely? Are there power imbalances at play? For example, is the physician dominating the conversation? For an example of this, a 90-year-old patient with dementia has pneumonia. Do we treat that patient aggressively with ICU support, or do we provide comfort care and let nature take its course, as that patient is old and probably closer to end of life, and intervention could provide undue suffering for them? Each path has their trade-offs. In this step, you have to choose. Ethics is not just theory, it's about action, especially in urgent medical situations. So this brings us to step 5, which is our critique. This is a step that most often gets skipped, but it is critical. After a decision is made, we need to reflect on it, anticipate objections, ask ourselves, did we miss anything? Ethical decisions should be reviewable and revisable. Sometimes new information comes to light or a better solution emerges. Being open to critique is part of ethical maturity. So for example, a patient's feeding tube is withdrawn based on their living will. But later, a family member provides evidence that the will was written under duress. Should the decision be reversed? Does the ethics committee need to get involved? Remember, critiquing does not mean being defensive. It means being open, thoughtful, and committed to doing the right thing, even if that means changing course. In hospitals, This step might involve ethics consultations or committee review, especially in cases of unresolved conflict or systemic concerns. So together, these 5 steps within this framework that have been presented, they include clarifying facts, identifying the issue, framing the issue, evaluating and deciding, this is our action step, and then finally critiquing and reviewing that action. Those 5 steps within this framework give us a structured, repeatable, and compassionate way to navigate the messiness of real-life ethical dilemmas. You'll be using this very framework in your case study assignments this week. And now that we've gone through the Georgetown ethics workup, let's apply it to some of the most common and controversial ethical issues in end-of-life care. These are types of scenarios where clinical facts, legal standards, personal beliefs, and cultural norms all collide, and where the ethical terrain can feel incredibly murky at times. So let's unpack them one by one, starting with physician-assisted suicide. This is one of the most debated issues in end-of-life ethics. Physician-assisted suicide refers to a situation where a physician provides the means, typically through a prescription, for a terminally ill patient to end their own life. It's distinct from euthanasia, where the physician administers the life-ending medications directly. Legally, physician-assisted suicide is permitted in a handful of United States states under death with dignity laws. Oregon was the first, followed by other states like Washington, California, or Colorado. Ethically, it is divisive. Advocates argue it respects autonomy and it relieves suffering. Critics argue that it violates nonmaleficence and the traditional role of medicine as life-saving. Religious and cultural backgrounds often shape people's views here. For example, the Catholic Church strictly opposes physician-assisted suicide, while some secular ethicists support it as a compassionate option. Then we have pain management and the principle of double effect under this. So this is another major issue, especially near the end of life. So doctors may prescribe powerful opioids or sedatives that relieve pain, but they may also suppress respiration, potentially shortening life. So this raises a similar ethical question. Is it acceptable to provide medication that may hasten death if the intent is to relieve suffering? So this is where the principle of double effect come in. It states that if the action itself is morally good, such as relieving pain, the bad effect, such as hastening death, is not intended, and the good outweighs the bad, then the action can be ethically justified. This principle allows clinicians to provide adequate pain relief, even when doing so might unintentionally shorten a patient's life, as long as their intent is not to cause death. And then we have a second ethical issue that we can address, defining death. So this might sound really obvious, but even the definition of death is ethically contested. Traditionally, death was defined as cardiopulmonary death, when the heart and lungs stop functioning. But today we also recognize brain death, the irreversible loss of all brain activity, as a legal and medical definition of death. However, some people, for religious or personal reasons, reject brain death and believe life continues as long as the heart beats. Then this brings us to withholding versus withdrawing treatment. So this is another ethical tension, and understand that difference between withholding care and withdrawing care. So withholding means choosing not to begin a treatment, such as not putting someone on a ventilator. Withdrawing means stopping an ongoing treatment. That would be turning off the ventilator if it isn't already in use. So clinically, the two are considered ethically equivalent. But psychologically and emotionally, withdrawing often feels much harder, as if it's more active. Instead of choosing not to intervene, you have intervened and now you are rolling back that intervention. This is especially difficult for families and care teams who may feel that they are causing death from withdrawing that care. But even if it's consistent with patients' wishes or best medical practices, there still may be that emotional consideration that comes along with it for the care team or for the family. So it's very important to guide families with clarity and compassion through these moments of the choice to withhold care or the choice to withdraw care if it is medically called for. Then we have medical futility. So this refers to interventions that are unlikely to benefit the patient in a meaningful way. So for example, performing CPR on a patient with multi-organ failure who is actively dying. The ethical dilemma here is, when does treatment become more harmful than helpful? Clinicians may feel obligated to offer everything while also knowing that some treatments only prolong suffering. Clear communication and advanced care planning can reduce these situations, but disagreements between families and physicians can and do occur. Then we have the moral value of the physicians. So physicians are people too, and they can bring their own values to the bedside. For example, a doctor who personally opposes physician-assisted suicide may feel morally unable to participate, and legally, in most states, they are not required to. But ethically, they do have a duty to refer the patient to another provider who could fulfill that request. Balancing personal integrity with professional responsibility is an ongoing challenge in medicine. And finally, we have the spiritual beliefs of the patient. So we cannot ignore the role of spirituality and religion in end-of-life ethical decision making. These end-of-life decisions often prompt existential questions such as, what happens after death? Is suffering meaningful? Is it wrong to refuse life-sustaining treatment? Patients from different traditions, Judaism, Islam, Hinduism, Christianity, Buddhism, they all have deeply rooted beliefs about these issues. Some may want every effort made to preserve life, while others may prioritize dying peacefully at home. As providers, our role is to respect and support these beliefs, even if they differ from our own, and even if they challenge medical instincts. So as you can see, end-of-life ethics is not just about medical decisions. It's about values, culture, emotion, and meaning. These are the very issues you will grapple with during these week's case study discussions, so keep these examples in mind as you apply the Georgetown framework. Now it will be your turn to engage. This week you're going to read 3 end-of-life case studies that will be posted on Canvas. And for each one, you're going to respond to 3 reflection questions that will be provided. These will be your discussion board posts, so your initial post will be due Thursday, and then you will reply to at least one classmate by your normal Sunday due date. So let's aim for a rich, respectful dialogue and dig deep into these case studies the way you guys have been on your discussion boards in the weeks previously. Also, for your movie and reflection this week, I've given you 2 options. You can choose between Wit, which is a more stylized movie that's a little bit older with a little bit more of a clear, streamlined story to tell, or Endgame, which is a little bit more recent, but it's in a documentary style. So Wit is available on the Troy Films on Demand. Endgame is a little bit newer, but it's only available on Netflix. So if you don't have access to Netflix, feel free to just go ahead and do Wit. You'll do your reflection on one of those 2. You get to choose, and that'll be due the following Wednesday. And then just to keep it on your radar, looking ahead, we're going to have exam 1 next week during week 6. And that is the same week that we're going to begin our unit on environmental ethics. So as always, if you have any questions, you can message me on Canvas and I'll try to respond to you within 24 to 48 hours. Thanks for being open to this week's topic. It is not an easy one, but it is incredibly important. I'm looking forward to all of our discussions, and I will see you all next week.